just so I don't forget. Josh, thanks a lot for presenting today.
Yeah, thanks for the invite.
We'll give it a few minutes.
So it's 20 or 25 minutes in questions or discussion, I should say.
20 would be better just to
Okay,
give it a little bit more time for
faster
a chat. Yeah.
Couple slides that I think everybody probably knows what's on them. So
what was the talk title again?
finding the middle ground between
Finding the middle ground. Yeah,
everybody's
I like
strong
that.
opinions.
Yeah, I really like that. What do we do with the data we've got? And some people feeling like they know. All right, looks like we've got a pretty good crowd, so I think I'll get started. Welcome everybody to the Mirror Grand Rounds ICH presentation, and this is an effort building off the Mirror Registry, which is a prospective registry for patients who undergo early evacuation with the surgiscope. And we've got about 12 centers active now and a few more activating. And we've enrolled about 80 patients at this point, I think. The goal here is to kind of understand how minimally invasive ICH evacuation is being applied in the real world and to learn and communicate the nuances of the systems of care and the procedure itself and the follow-up care so that we can continue to move the field forward between the major trials. And so today we've got Josh Osbun, who's associate professor at WashU, giving us a talk on the finding middle ground between the evidence we've got and strong opinions, which is really ideal, especially when we're applying this in the real world, perhaps within or perhaps beyond the randomized clinical trial data that we've already got. Before I hand over to Josh, I just wanted to say that in the last month since our last meeting, we've had a real tragedy occur in our space where one of our site PIs in this study, Justin Singer, passed away tragically. And so I just wanted to honor him and comment that he really played a pivotal role in forming this study and getting this group together. And there were many, many nights where he would be on a call while I was doing a case or other people doing a case and commenting and giving his thoughts. And he was a real leader in our space and someone who pushed the limits as a clinician and as a researcher. And it's really a hard loss to be felt. And so we'll, I think, find a way as a group to honor him as we go forward with this through our publications and acknowledgements. So I think with that, I'll pass on to Josh. Thanks a lot, Josh, for giving a talk today.
Of course. Well, thanks again for the invitation. I will see if I can share my screen here. That's showing up okay for everybody?
Yep, looks good, except you've got the slide list on the left there. So if you go full screen there.
There, got it.
Nice.
Okay, well, again, thanks for the invitation. And thanks for taking a moment to honor Justin. Definitely a friend of mine and somebody I talked to a lot over the last 15 years, and huge loss for us. I have a couple consulting agreements that are not really relevant to this talk. And just kind of given the spirit of what Chris is trying to do with this series, I thought I would kind of maybe talk a little bit about how ICH has evolved since I became a resident back in 2006. And then kind of what our choices are in techniques, what's worked for me and what didn't. Where I think the evidence for MIS evacuation of ICH stands today, and then maybe address a little bit about the strong opinions about where we should take the field and what's practical for busy cerebral vascular neurosurgeons, or to be honest, busy general and spine neurosurgeons. And I'll talk a little bit about how we triage ICH here at my home institution, WashU, and a little bit of the workflow between neurosurgery and neurology. Acknowledge a little bit that I may be missing a few potential cases based on our workflow, and just real world issues, and then talk about how I kind of currently practice based on putting all this together. So just some disclaimers. I like to point out bias where bias is, and I'm a dual trained cerebrovascular neurosurgeon at a high volume comprehensive stroke center. I've got a lot going on, and I think I would be lying if I didn't say that everything that's going on doesn't influence my choices for how I manage ICH, when I operate, how I operate. And I don't get to operate in an ideal world for every case and every patient. And I make choices that are based on time of day and how much time it's going to take me to do the case. I think as a open neurosurgeon, I have a very large bias towards operating with two hands. And I think because of this, it also influences the techniques I choose and makes a couple more natural for me than others. And it's really driven how I do my cases at this point. And then I just want to say I do not personally consider myself an ICH expert or thought leader in the field, and is not a research focus of mine. So a lot of this is just me presenting to you as somebody who I consider to be an end user of the ICH consumer market, trying to work in the real world at a comprehensive stroke center. And I'm certainly not somebody who I think is driving this field right now. I'm just sort of an everyday user of what's out there. And I guess where I don't see clear evidence, I will probably be expressing my own strong opinions in this talk. So I just think it's important to point out these biases. So kind of typical case that I see, this is a 50-year-old with hypertension, comes in with this scan. He's GCS 7. He's pretty hemiplegic on the right side. He's not following commands at all. This is somewhere between 100 and 110 cc clot, depending on where you draw your lines and you do the ABC over 2. And he's got reactive pupils. He's relatively stable. He's been admitted to the ICU, and they're, on top of blood pressure and everything else pretty well. So what do you do with this patient? I think you could observe, possibly get a stability scan in a few hours, reassess. Some people might consider intracranial pressure monitoring. I think some people might consider an EVD. Some might do a hemicraniectomy, possibly do a more open evacuation of the IPH, either under your loops or the scope. And I think, a lot of people would consider a minimally invasive approach, evacuate this clot. And then, what are you going to do if it's 1 a.m, and is that different than what you're going to do at 1 p.m. in the afternoon when you're awake and fresh and there's an available OR? And, that's I think a real question. At 1 a.m, does all this for surgery wait until the morning, or do you do it at 1 a.m? And then just personally admitting, I'm probably more likely to call this an emergency and take the patient to the OR as soon as possible at noon than I am in the middle of the night. And I think that's a real world bias we have to address. ICH is a very heterogeneous disease, and it comes in a lot of flavors, a lot of sizes, with and without IVH. These are all various scenarios that have just come up in the last 2 weeks taking call. Everything from a pretty large thalamic down into midbrain hematoma with some interventricular extension and a very poor exam patient. Another kind of smaller volume hemorrhage, not showing you all the slices, but this one, it does actually measure out to be about 15, 16 cc's. Exam's better. And then a case I dealt with a couple weeks ago where I've got a high functioning 85-year-old who is actually our former chair of general surgery here at our institution. Just given a large presentation to all the departments of surgery as a professor emeritus the week before. And then he comes in with a temporal IPH, and it's about 30 cc's in size, and he's got a little bit of a decline in his GCS. And so do you offer this patient something, or do you watch this? And I think these are all the questions we have to ask for all these different types of hemorrhages every day. Kind of going back to the history, when I was a resident, when I was an intern and junior resident, we managed most ICH very conservatively. Some people got EVDs if they had interventricular extension. Anybody who wasn't following commands, we tended to place an ICP monitor, and then ultimately do a decompressive craniectomy if there are high ICPs. If the clot was coming very close to the cortical surface, we'd often do a clot evacuation. And then we really only had stitch 1 to go on, which came out right before I started residency. At least the way I was taught by my faculty to interpret stitch 1 was that you could consider surgery if the volume was 60 cc's or less, the patient was less than 65 years old, and a hematoma came within 1 centimeter of the cortical surface. Otherwise, this was managed relatively non-operatively. And then we had outlying cases where we had scans like this, and if I had a board faculty whose case had canceled that day, they would sometimes go after something ridiculous like this. And I just felt like the message was always very inconsistent and always confused as a resident about how to manage ICH. And I remember many times asking my patient or my faculty, why are we taking this patient to surgery? One time I asked this to my co-resident, Mike Levitt, who said, because there's level 1A evidence in the International Journal of Strong Opinions, which I thought was a great quote, because we didn't really have a reason why we were doing this. We just sort of did it because we felt like it, or it just felt like a good gestalt for us. I feel like this general sense has governed ICH for quite a while in our field, and we're just now getting some reasonable evidence in the last couple of years. So again, Stitch 1 was a fairly well run trial, many centers, international, in many countries, had a lot of patients in it. And, at the end of the day, it was a relatively negative trial showing no benefit to early surgery compared to conservative management. There was this subgroup for lobar hemorrhage that was a smaller volume and within a centimeter from the cortical surface that might have a benefit. That's where sort of stitch 2 was born out of. When I was a PGY4, I spent my entire year of residency in the UK, and we were an active enrolling center for stitch 2, and I ended up rolling 10 patients or so in stitch that year. I will have to say that with the cumbersome enrollment process and the kind of core randomization center, oftentimes these patients finally got enrolled well after 12 or 24 hours and were a little bit outside of the intended criteria. Again, stitch 2 was looking at smaller hemorrhages and a little bit better GCS than stitch 1. And, essentially they concluded that early surgery doesn't increase the rate of death or disability at 6 months, but may be clinically relevant for patients without IVH in terms of a survival benefit. And you can see there's not a large shift in the MRS at 6 months, and the Kaplan-Meier curve does look like there's at least a little bit of a distinction in the survival benefit. And, the English are very fatalistic. They want to see a big shift in the outcome, and they also want to see it in the lower end of the MRS score. They don't consider reducing the number of MRS 5s and 6s as a good outcome. They want to see that your effect is all in that 0 to 2 group. And if it's not, and you're just reducing death, but you're not increasing functional outcome, they consider this a worthless procedure, and that's really how they operate it. And I think there's something to be said about their general societal differences and how far they'll take patient care and what they want as a good outcome compared to the average American. Once I became a senior resident and moved into being a junior faculty member, I really saw that our meetings, MIS ICH evacuation was really dominating all the vascular neurosurgery sections of meetings, and we started seeing more and more techniques for minimally invasive evacuation, kind of thinking, are these big craniotomies with large portosectomies causing too much damage on the way in? And is that why stitch 1 and 2 are really not giving us much of an effect? And we really just need to slip in a little bit more seamlessly, remove the hematoma and leave the damage in the brain to just what the hematoma caused, and not our actual surgery. If we look at how the guidelines have changed, these came out right as I started as faculty, after I finished training. And I think there are still a lot of vague, unanswered questions. For supratentorial ICH, the usefulness of surgery is not well established. There might be some subgroup considerations where it is more effective. In general, a policy of early hematoma evacuation is not clearly beneficial, and the effectiveness of MIS clot evacuation with stereotactic or endoscopic aspirations does not have a certain utility at this point. So, basically just foreshadowing that all these things are being looked at, but nothing has really been a clear reason to do these cases. Fast forward to 2022 for our latest guidelines, which already in 2024 are out of date. And at least they're saying that MIS demonstrates a reduction in mortality. However, they aren't willing to say anything besides that the functional outcome with these procedures is neutral and unclear. Are we actually making patients better at the end of the day, or are we just keeping them from dying? Certainly a little bit more leeway that's reasonable to take patients with greater than 20 mLs of hematoma with a relatively wide range of DCS 5 to 12. Certainly, giving a little bit more credit to MIS techniques, and still unclear whether sort of a MISTI type protocol where you place a catheter and infuse TPA is going to be effective. Really saying that large open craniotomy is very uncertain and no clear benefit to outcomes, and that it might be a life-saving measure at the end of the day, but fairly weak evidence to say these things. So we still have very vague guidelines at this point. So what can you use these days? This is the MISTI technique. I want to thank Mike Chacoin, because I think I borrowed a couple of these pictures from a slide he gave me one time. But essentially here, you drilled a burr hole, you stereotactically guided a catheter into the brain. Through this sheath, you would see what you could aspirate at the time. You'd leave sort of an EVD type catheter behind, and then infuse TPA over a few days. You had to make sure you had a stability scan, absolutely sure that you didn't have a spot sign or a bleeding vessel before you did this, because this is a fairly blind procedure and you're infusing a thrombolytic into the brain when you do this, which can be dangerous. And then, BrainPath came into the fold, around 2012 or so. Gustavo Padilla kind of looked at a pilot study called the MySpace trial, and then this evolved eventually into Enrich. And this was sort of a port system that you stereotactically guide into the brain, and then you had to look through this tube with either an endoscope hovering over the patient, or the microscope straight down the tube. And I did many brain bath cases in my first few years as an attending. Always found the visualization very clunky, and every time you move the tube, you had to move your visualization instrument, and it was just very cumbersome workflow in my opinion. But I like the bimanual control using some of their larger tubes. I like that I could potentially have a suction and a bipolar, or a suction and another instrument at all times, and I felt like I could relatively effectively control bleeding. And so it was a reasonable case once I got down the setup and navigation and everything. These really ended up only being about an hour-long case, and it wasn't too bad. And then it was actually being studied in trial, which I liked as well. Another thing that's come out in the last few years is sort of the penumbra artemis, and sort of endoscopically looking into the hematoma cavity through a small burr hole and sheath. This has been dubbed the scuba technique, where you kind of flood the cavity with irrigation. You can see better with the endoscope. possibly put a bug wire down the endoscope and cauterize a bleeding point. And it's a lot of in and out, in and out. I'm going to be honest, I did this technique about 12 times. It just did not work for me, and I never mastered it. And I found it very frustrating. It worked great if there was just a hematoma that wanted to suck out and no bleeding in the cavity and you were done. But if I had to manage any bleeding, I found that very difficult, and I never really ended up putting the time into learning this technique well. I'm probably doing the 30 or 40 cases that would have required me to master it, because I found that to be just a frustrating system to use. And I had about a 50% return to the OR rate with this technique, because I just wasn't good at it. And I was just much better at the other technique because it was much more natural for me as a surgeon. And then now I've kind of landed more on the Surgiscope system. And we're, of course, studying this in the mirror registry. I like the visualization. I like that the camera moves in unison with the tube, and I can move the tube around, and I'm always seeing at the bottom of it, and the lighting is good. I tend to use it with my skull-based microsurgical instruments. I have long shaft bipolars that even extend out beyond the 100 millimeter tube. I have long Fukushima suckers I use. And sometimes I even use the EndoPen that I would use in pituitary surgery. And so for me, the Aurora is very much like pituitary surgery, which I have a lot of experience with. I feel like I can control bleeding, and I have bimanual control. And even when I'm using the small tube, it tends to work better. So this is mostly what I've settled on at this point after trying a bunch of things. We're studying several things right now. We've got some results from some trials, others we don't. Misty 3, ultimately ended up being a relatively negative trial comparing the catheter infusion of TPA and aspiration to best medical management. And we really only saw a little bit of a reduction in mortality and nothing else in that trial. And I find that technique just very cumbersome and labor intensive over several days. And it's just not something that I think is practical at this point. And Rich finally finished, and we got a nice New England Journal paper out of. I think this is a relatively decent trial, but it's still messy. Their adaptive design meant that they ended up throwing out a large number of cases and stopped enrolling basal ganglia cases. And so you have a little bit of a mixed patient population in this trial. Nonetheless, just looking at a utility weighted modified ranking scale, which is a more patient reported outcome measure and kind of a weird 0 to 1 scale with a lot of decimal points. I don't think most of us are used to using that scale. It was a positive trial, demonstrating, both in the overall group, including the basal ganglia hemorrhages, that surgery was beneficial to the patient compared to best medical management. This used Bayesian statistics, which is a little bit of statistical wizardry, which I think certainly helped this trial out compared to more traditional statistics. And so, what does all this mean in English? I think we do see a nice MRS shift, at least for lobar hemorrhages in that time frame and that clot size. Mind and invest for the Artemis system. I don't know if we'll ever get the full data set. I hear Mind is in publication potentially, and certainly I might change my mind on that if there's compelling data out of that, but I haven't seen it yet, and I found that system frustrating, so I don't use it. I think unanswered questions at this point, clot location other than lobar. Are we ever going to go after basal ganglia or thalamic? I think this needs to be studied. What's the maximum and minimum size range of the clot that we're going to get a benefit from? And then what about timing? Is 24 hours good enough? Do we need to be doing this in less than 12, or do we need to be treating this like thrombectomy and get it to the OR as soon as humanly possible, and do these door to burr metrics that Dr. Kellner has been talking about lately? I think we're at a very similar place to where we were in stroke, where we had a lot of negative and messy trials with a lot of mixed patient populations and different devices. And once we standardized this and really focused in on some very specific achievable metrics. We started getting positive trials in stroke, and now, thrombectomy has really taken off. I think we really need to do the same with ICH, but the patient population on the whole is much smaller. The results and the effect size are much smaller as well, and so we don't have as big of impetus as we do with stroke, and it's expensive, labor intensive, time consuming to run these trials. And so I'm not sure we're ever going to be able to get the granular data that we're getting every year with stroke through this. So, and then I think ultimately the technique we all set on needs to be easy, and anybody needs to be able to reproduce it. Just like the neurologists can, do with thrombectomy, even though they don't come from a procedural specialty, they do very good doing these techniques for stroke. And this really needs to be something that all neurosurgeons and spine surgeons can do as well, very easily, with reproducible results. Whether you're an expert who's done 1,000 of these cases, or whether you just need to do it 10 times a year at a community hospital. Some of these opinion pieces that have come out lately on, ultra early timing of surgery. Right now, I still think that these are opinions, and strong opinions, extrapolating a lot of data from imaging studies, early blood pressure management, reversal studies. But right now, this is very difficult for me to say that I'm going to treat every ICH the same way you do a thrombectomy. I already have a very busy practice, and I need that 24 hours of leeway to schedule these at convenient times for me in order for me to manage these patients and have somewhat reasonable of a career in life. And this is just not feasible for me right now. And it's going to require a large scale trial that shows me that, time is brain with this too, and the sooner the better. Otherwise, I'm going to continue to practice at about 24 hours or less. I'll speed up here. This is kind of what we're doing now. I'm really, as a neurosurgeon at WashU, only seeing the 30 cc's or greater hemorrhages, because the rest go to neurology and our triage protocol. Certainly, if they're sicker patients, they're going to come to me by our kind of GCS criteria. But I potentially am missing that 50 to 30 cc clot range that might be potential to do something about. And in our current triage, I'm just not even getting consulted on those, and our vascular neurologists just deal with them, and we never hear about them. So right now, I'm really not doing much less than 30 cc's in clot. So again, if we have a trial that shows that smaller range is beneficial, we'll have to redo our protocol, but that's kind of the way it works at my institution right now. So what are me and my partners doing now? We're really doing a fairly wide age range. No qualms about evacuation for a GCS of 5 to 14 or so, and a clot that's 30 to 100 cc's and low bar. We're shying more away from basal ganglia, is definitely not doing anything thalamic. And I think when we go outside of those general guidelines, we're having very meticulous family conversations and setting expectations, and not playing up that this is a life-saving procedure. And I think that's the wrong thing to tell patients. I think you need to talk about functional outcomes and not just make it a life or death decision, because if you give them that, they will choose life every time, and that may not be the best thing, and they may realize a few weeks later there are things worse than death. Again, I operate within 24 hours, but not overnight. And for me, the best system has been the Surgiscope. I'm not saying that because we're on a mirror registry call. I'm saying that because I've tried everything else, and this has just been the best and most natural system for me. So again, vascular neurosurgeons are very busy. Thrombectomy is getting unsustainable. We still own ICH. We've got a lot of other things we take care of. We might be taking care of even more in the future. And it's going to be difficult for us to sustain a pace where we, have another stroke type disease on our hands, doing these as, extreme emergencies all the time. And I think we really need to widen out ICH to really all of neurosurgery to make it sustainable if our indications are going to grow rapidly like stroke did. But I'd still like to see some RCTs that show me, more specific metrics than Enrich does. I think Enrich is a pretty good study and gives us a decent framework to work with, but these outlying cases, I'm going to have to see data before I start doing them. So I think it's an exciting time. And I think ICH has come a long way, and I really applaud all the people who are running these trials and pushing the limits of the field and trying to get us these answers. And just as a general everyday user of ICH equipment, it's been great to see how it's come forward over the last 15 years. So thanks. Sorry, I went a little long there.
Thanks a lot, Josh. That was really awesome. And I especially loved the Mike Levitt quote. It's hilarious. Any comments or questions?
Hi, Josh, and just wanted to make a comment as Wendy guy from Baltimore. I really enjoyed your approach. You seem to be a connoisseur of all the devices, and you seem to have tried all the devices. I'm wondering, in a clinical trial sort of situation where you're sort of saying, well, you want to use your device that you're comfortable with, and that you've done a number of cases. How many cases do you really need to do in order to feel confident with any particular device? You mentioned 20 to 30. I recall that in the MISTY trial, we basically asked people to have 3 successful procedures, and probably that was nowhere near enough. But
well, I don't know. Again,
no.
that's my opinion. And it all depends. I think when you're an operator or doing any device or technique, it's really what you're comfortable with. And for me, the tubular systems are very natural. The scuba technique was not natural for me. But that's me. Obviously people like Chris and Jay are experts at scuba, and they get great results with it. I think I personally would have to do, another 30 scuba cases to feel like I was good at it. So I think everybody's going to be different, but then that makes the trial messy, because are you testing the general technique and making the assumption that all these device systems are going to get fairly equivalent results in a person who's good at using them? And you're just really, saying, MIS or medical management, or are you going to actually compare device systems and try to prove that one system is superior to another? I'd say we need to be focused on, you choose what technique is best for you, and we answer more questions like timing and clot location and clot size than we are comparing, scuba to Aurora to Nico brain path to Misty techniques. So
Great. Thank you so much. Great talk. Thank you.
Maybe that highlights that you need some kind of evaluation of the success of the procedure. And it might be different for each device. Like, it might be in the double digits or higher for endoscopic, whereas for endoport or maybe even catheter placement, it's much more natural and much more common in our practice already. So it might take fewer cases to get there with those techniques. So there might be a difference by technique and then also by surgeon. Maybe the way to do it is have somebody do rolling cases until they're consistently getting, the surgical target. Something to consider. I don't think I've seen that kind of proficiency barrier to getting into a case before in a trial.
Yeah, no, I mean, I think, yeah, 20 or 30 cases to say you're good to do the technique trial is definitely going to be limiting.
Yep.
I'm just making the comment that for me, the one technique I found very difficult, and I assume there's other people like me out there who, find that harder than some of the other ones. And then, you may find that very easy and natural depending on what your experience is. I could see my pediatric colleagues thinking that scuba is very natural because they do a lot more, neuroendoscopy than I do. So.
Any other questions?
Yeah, Josh, I was going to say that was great. Nice overview of your kind of approach to it. And it's like you said, these clinical trials help, but if you look at the screening, each one of those trials had thousands of patients in it to get down to the 300 or 400 or 500 that were treated, and so a significant majority of these patients that we see don't meet the criteria for those trials, and so it's kind of dealer's choice what the surgeon feels is appropriate and what that discussion with the family is, which may be the most appropriate part of the whole thing. But But I wonder whether there may be a role of kind of a mixed strategy. Maybe for some of these deeper hemorrhages, maybe there is a role for the MISTI technique. Maybe putting a tube down there in the thalamus or the basal ganglia may not always the best way. If you put a little tube in there and put a little TPA in there, maybe some of those patients did okay. I mean, it's a challenge. It's kind of case by case, like so much of what we do in surgery. There's no black and white rules for a lot of what we do.
Yeah, I see Brian Janglitz on the call here. He's been advocating. I've heard him advocate in conferences before using a location-specific technique with maybe lower profile for deeper lesions and then kind of a port-based approach for lobar lesions.
Yeah, but I think it seems intuitive to me that you need a broader field of view superficially, and you want to narrow down your access as you go deep. I think, like Josh, I tend to gravitate towards the larger tubes, towards the 15 millimeter ports. So it's brain path and then surgiscope. Particularly superficially when you need to sort of see under the ledge of the affected brain or under the edge of the bone flap. It's very hard, I find, to do with a very low profile device. So I think they seem to be synergistic in large access superficially, mainly narrower access deep. And I agree with Dr. Chicoina that we shouldn't turn our back on the MISTI technique. I do think that there's still the potential for that particularly as a technique to get your toes wet in ICH evacuation, where there is evidence that the efficacy extends from 24 to 96 hours, and it's more approachable if you know how to use stereotaxy. So everything I agree should be on the table until we parse out what's optimal.
All right. Thanks a lot, Josh. I think with that, we'll call it. And we'll continue with the SciPI meeting on the other Zoom link. Thanks, everybody.